Cervical spine.
Okay, so with this treatment, I want you, like a suboccipital release, to sink in and provide traction cephalad in that suboccipital where those occipital epicondyles are, and then after 20 seconds, I want you to provide some lateral traction on that to help stretch out, doing a direct myofascial release. So again, my fingers are sunk in, and I'm providing traction. And then, let's say 20 seconds have passed, I start providing some lateral traction to stretch out those cervical muscles as a direct myofascial release.
Thoracic and lumbar spine myofascial.
So again, with this treatment, there's a screen. I'm going up and I'm pushing. I'm checking the contralateral erector muscles. And then I go to the other side and push this way, checking these ones. As I screen, this area was tight, treating it directly with myofascial release. I'm sinking my thenar and hyperthenar eminence in, my thumbs as well, and I'm just pushing laterally to stretch directly using myofascial release.
Myofascial release for the scapula.
So with this treatment, your cephalad hand goes right around here with your fingers going into that scapular spine, thumb going around the front to the clavicle. Your caudad hand goes underneath. Now you have control of that scapula. I can screen cephalad, crawdad, medial, and lateral to get my diagnosis, and then I can directly and indirectly treat it.
Fascial for the forearm.
So again, we're going in and we screen first. I'm just doing lateral traction, working up that forearm all the way up, and then checking towards that medial epicondyle for tenderness and for tightness. I can then rotate and do the same thing, going up this extensor compartment. And then as I get up towards the top, there's muscles over here I want to check, and then going up towards that lateral epicondyle. Say I found tightness here. I could directly treat it by providing traction. I could indirectly treat it using compression or compression. I could indirectly treat it using compression this way, or traction this way, directly treating it. There's a lot of different ways to get in there. Just remember, myofascial release is 20 to 60 seconds.
Myofascial release for the carpal tunnel.
So with this treatment, your fingers are going around back and providing support on that wrist. Your thumbs are going at the base of the thenar eminence and the hypothenar eminence, and you're providing compression and lateral traction with slight extension of the wrist. Another way to do this technique is putting your fingers in like that. Again, fingers going around, providing that compression and lateral traction. Notice the blanching. Look at it.
Myofascial release for the popliteal fossa.
So with this myofascial treatment, again we screen. I'm going to only show you unilaterally, but you will do this screen and treatment bilaterally. Again, my fingers going on, providing medial traction to the medial hamstrings, lateral traction to the lateral hamstrings. And then again down here, medial gastroc with medial traction, lateral gastroc, lateral traction. I found tightness up here, so I'm going to provide traction, and I'm going to allow gravity to stretch out those muscles. So this is a direct myofascial release. And then afterwards, I'll rescreen.
This is diagnosis and treatment for the AC joint.
Okay, so first screening the AC, you're going to have your fingers over the clavicle, your palms are going to be over the AC joint, and your thumbs are going to be over the spine of the scapula posteriorly. You're just going to screen from anterior to posterior, seeing which side is more dysfunctional or has less spring to it. For this, we'll say that it is his left side. I will then check that by placing my hands here with my thumbs over the spine of the scapula, and I will get down eye level and see if it is the spine of the scapula is higher or lower on that side. If it is higher on my dysfunctional side, I will name that a superior AC joint. If it is lower on that dysfunctional side, we'll call that an inferior AC joint. Since his is actually lower on the side, I'm going to call this an inferior AC joint. The treatment for both of these is the same. It's just going to change the position of his palm for the two different treatments. So for an inferior AC joint, I'm going to have the palm pointed down or pronate it. I'll then have my leg on the table just to rest my arm. You want to make sure that your hand is proximal to the elbow joint. It's actually on the humerus. Okay, you're not completely laterally, but you're a little bit anterior. You can think about this just being in line with the scapula. You want to make sure and have a good handhold on the scapula and actually compress down. This will make sure that you're isolating your treatment just to the AC joint. Okay, I'll then bring him up until I feel motion under that second MCP joint or the MCP joint of my index finger. I can then have him make a muscle energy effort by pushing down into my hand and relax. And then I can bring him into the barrier by bringing it up into more abduction and press down and relax. And then one more time, press down and relax. And then I can have a passive stretch and then back to neutral. And I would then re-screen by checking the heights of the spine of the scapula again.
This is the diagnosis and treatment of the SC joint.
Okay, so for SC joint, you're going to be medially on the clavicle. You're going to have your index fingers just superior to that SC joint. I'll then have the patient shrug their shoulders. Okay, and I'm checking for the side that doesn't move caudate. Okay, so normally, go ahead and shrug your shoulders again. They both should move inferior. If one stays superior, I just notice that it doesn't move, that's going to be my dysfunctional side. Will come anterior to my patient, and I'll place my thumbs over that SC joint superiorly, and I will compare them together to see if one side is higher or lower. If my dysfunctional side is higher, I will name that a superior SC joint. If my dysfunctional side is lower, I'll name that an inferior SC joint. For my treatment of the superior SC joint, I want to try to pull it back down. I'm going to do that using the subclavius muscle. So I'll come around here, and I have my thumb over top of that joint and my index finger underneath the SC, or just the medial end of the clavicle. I'm then going to bring the arm into extension, a little bit of abduction. I can then have him make a muscle energy effort by pushing forward and relax. And I can take him into further extension, taking out that barrier, and again push forward and relax, and one more time and relax, and then passive stretch at the end, and I can take him back to midline. I will then re-screen by checking the heights of the SC joint. I'll also have the patient shrug their shoulders again to make sure now they're both moving inferior, and I'll also compare the heights of the spine of the scapula to see if they are now even. For the inferior SC joint, I want to try to pull it back up using the sternocleidomastoid muscle. Again, I'm going to be my thumb inferior and my index finger superior to that medial end of the clavicle, monitoring there. I'll then engage the barrier by side bending the patient's head. Okay. As soon as I feel motion at my thumb, I'll then have them push into my hand, firing that sternocleidomastoid and relax, and then further into the barrier and push, and relax, further into the barrier, and then one more time, and relax. Then I can do a passive stretch back to midline. I would then re-screen again by comparing the heights of that medial end of the clavicle at that SC joint, having the patient shrug their shoulders, and then finally I would check the heights of the spine of the scapula posteriorly.
For the upper thoracics.
So we already found our diagnosis. We've already put our thumbs on the transverse processes, had them flex, had them extend. So what we're going to do is we're going to treat a T2 lesion that is, let's say, FRS right, using post-isometric relaxation muscle energy. So the first thing I'm going to do is make sure that I'm using my 2-finger placement so that I can make sure that I'm localizing. I'm going to twist his head, make sure that I'm on the correct vertebra. So here's T2. One finger in the spinous process, the other in the transverse. His diagnosis was FRS right, so for post-isometric relaxation, I'm going to put him into the barrier of ERS left. So to do that, I need to make sure that I stay localized. So small movements, extended, rotation, side bending. Now that he's in the barrier, I'm going to ask the patient to go ahead and try and straighten up. 1, 2, 3, 4, 5, and relax. When he relaxes, I'm going to take him further into the barrier, more extension, more side bending, more rotation. Try and straighten up again. 1, 2, 3, 4, 5. Further, try again. 1, 2, 3, 4, 5. So once this is over, I'm going to passively bring the patient back to neutral. Then I'm going to reassess and see if my treatment was effective.
Muscle energy for the lower thoracic.
So now we're going to treat a dysfunction in the lower thoracics. Let's say that you already have a diagnosis, so you already were palpating transverse processes, already had them flex, already had them extend, you created your diagnosis. So let's just say that I'm putting my fingers on T8 spinous process and transverse process, so I'm monitoring for localization. Let's say that his diagnosis is ERS right. I'm going to treat him with post-isometric relaxation. So I'm going to put him into FRS left using his shoulders because it's lower than T4. So I'm going to flex, side bend and rotate, only down to the segment, making sure that I'm staying localized. Then I'm going to have him try and straighten up. So 1, 2, 3, 4, 5, relax. Then bring him further into FRS left. So further into the barrier, straighten up, and relax. A little bit more, straighten up, and relax. So at the end of the treatment, you're going to bring them back to neutral passively, and you're going to rescreen to see if your treatment was effective.
The diagnosis of the radial head.
To diagnose the radial head, you'll have the elbows at 90 degrees flexion. Okay. You'll then pronate and supinate the arms to see if there's any dysfunction. Okay. You're looking for a restriction. When you get there, you can kind of spring a little bit at the end of each of those motions to see if you have a restriction in any of them.
This is the treatment for the radial head.
Okay, so we'll say that on this left side, we found that he was pronated. So that means that I found he could pronate on that side, but he was unable to fully supinate. So I'm going to start in that barrier of supination, and of course I'll be monitoring here laterally on that radial head. Okay. So I'll have him supinate to the barrier, and I'll have him do a muscle energy effort by trying to push his hand over into pronation. So push and relax. And I'll further engage the barrier and push and relax. And then one more time, push and relax. And then passive stretch at the end, take him back to midline, and then I would re-screen by pronating and supinating his forearms.
Reciprocal inhibition, muscle energy of the bicep.
So now we're going to treat the bicep. The first thing that you're going to do is palpate for tenderness. He's going to be tender around here. So what I'm going to do is I'm going to bring him into his restrictive barrier, which is lengthening the muscle, which is muscle extension. So then for reciprocal inhibition, I'm going to be firing the antagonist muscle. So I'm going to be firing the triceps. So I'm going to have him in his barrier. I'm going to ask him to extend his arm out. 1, 2, 3, 4, 5, and relax. Once he relaxes, I'm going to take him further into the barrier, which is more extension. It's the same restrictive barrier for the muscle that you're treating, which is the bicep. So now that we've already moved him, go ahead and extend again. 1, 2, 3, 4, 5, relax. Extend them more. 1, 2, go ahead. 1, 2, 3, 4, 5, relax. And then passive stretch, back in neutral.
This is the Spencer technique for the shoulder.
So for Spencer technique, you're going to take your cephalad hand and you're going to just be on the scapula, maintaining good contact there. For most of these treatments, your other hand is going to be on that elbow joint. Okay. The first motion of Spencer technique is going to be extension, so you can move them back into that extension barrier. If I feel restriction there, I can have them push forward into flexion and relax. Move them further into the barrier, push forward and relax. Further into the barrier, and then one more time, push forward and relax. I will then take them into flexion. Okay, so I will move the arm up into flexion. Okay, if I want to do muscle energy here, I can have him push down into my hand and relax. Further into the barrier, and again push into my hand and relax. Okay, next is going to be my compression. So I'll bring the arm up on top of the elbow joint here, and I'll just press down through that, and I'll do circumduction. So I'll start with small circles, and then I get larger. So I work out getting that full range of motion. I can then reverse that and do the opposite. My fourth stage will be traction. So I'll take my thumb under the elbow joint here, and I'll lift up, applying traction to that glenohumeral joint. And then the same thing, I will start with small circles, working my way out, and then I can reverse that motion. From here, I'll move into abduction. Okay, so I'll take the elbow and move that into that abduction barrier. If I want to do muscle energy here, I can have it pushed into my hand and relax, and move it further into the barrier and push into my hand and relax. Next, I'll do adduction, external rotation. So from here, I'll have his forearm on top of mine, and I'll grab the humerus. I'll then push it midline, creating that adduction and external rotation. If I want to do muscle energy here, I can push up into my hand and relax. And again, relax. Next, I'll do internal rotation. So on this one, I can take his hand posteriorly behind his back, maintain a good contact there on the anterior shoulder. Take my hand posteriorly here. I can bring his elbow towards me, and that will create that internal rotation. And then I can have him push against my hand and relax. And again, push and relax. And one more time. And the last step, I will do the lymphatic pump. I'll take his arm over my shoulder. I'll take my thumbs underneath the arm and my fingers on top of that deltoid. And I'll just move that joint back and forth, trying to grind that humerus against the glenohumeral joint.
Facet model. So now we're going to diagnose the cervical lesion and explain what the facets are doing. So my primary goal is to induce side bending by translating to the right and to the left during flexion and during extension. So the first thing I'm going to do is flex the patient's neck, translate back and forth to assess for side bending of the neck. Everything feels totally fine when he's in flexion. So I know that during flexion, everything's fine, meaning that the final diagnosis will have a flexion component. So then I put him into extension, do the exact same thing. I'm going to translate back and forth. During extension, it's really difficult for me to push from the right side to the left side, which means that it's really difficult for him to side bend to the right during extension, which means that what he can do is side bend to the left. So if you're naming the diagnosis by what it can do, that means that his diagnosis is flexed, side bent, and rotated to the left. So now if we think about what the facets are doing for FRS left, we go back to our hand model. During flexion, everything opens up totally fine. Everything's perfectly fine in flexion. So that means that during extension is where you're going to have your issues. So during extension, you're side bent and rotated to the left. So the left facet is closed, the right facet is open. So during flexion, both facets open normally. During extension, the right facet closes normally, or the left facet closes normally, and the right facet pathologically stays open. So that's what the facets are doing.
Strain on the practical, I'm first going to go through all your cervical points. So remember that in lab we didn't go through every single cervical point, but you still need to know those for the practical. Your AC1 is going to be just behind the mandible. The rest of those are going to be anterior to the transverse process. So 2 will be here, 3, and so on down till 6. AC7 is going to be the clavicular attachment of the sternocleidomastoid, and AC8 is going to be medial to that on the sternocleidomastoid. For each of these treatments, you want to palpate the point. We'll just do AC6 here. You want to, in completely neutral, you want to tell your patient this is going to be a 10 out of 10. You will then position them, which for this counterstrain point is going to be flex, side bend away, rotate away. I will then press again and ask the patient what this pain is, and I'm looking for them to tell me a 3 out of 10 or less. I'll then release pressure of my monitoring finger and hold this position for 90 seconds. Once that 90 seconds is up, Then I will passively bring the patient back to neutral and rescreen by pushing that point and seeing if I got it down to a 3 or less. Guys, remember AC7 is that clavicular attachment of the sternocleidomastoid. The difference on that one is once you find that point, you will position the patient in flexion, side bend towards, and rotate away. So it will look like this for that point, but you'll follow that same treatment protocol. I'll show you the counterstrain treatment for the posterior cervical points. If you can see my finger here, this will be just under the inion, and this will be PC1 midline. For that treatment, I would flex the patient up. Okay. If I come out lateral, about right here, I'll show you on this side, is my PC1 lateral. PC2 lateral is going to be right here. Midline PC2 is going to be there. The only other one you need to remember is PC3 midline is actually flex, side bend away, rotate away. All the other posterior points, let's just take this one, let's say PC4 lateral, you will use treating extension, side bend away, rotate away. So for this one, I will start in neutral and say this is 10 out of 10. I will then extend, side bend away, rotate away, and then I'll ask the patient when that is down to 3 out of 10 or less. Then I will release pressure on monitoring finger and hold this for 9 seconds. Sometimes it's nice to offer your patient some of your food if you're eating.
Can I have some of that chicken?
No, actually I need to do all of this for my gains, I'm sorry. Once your 9 seconds are up, then you will passively bring them back to midline, maintaining contact on that point, and press and see if you got down to a 3 out of 10 or less. That is your rescreen. Anterior thoracic points 1 through 6. You're going to find 1 just above that sternal notch, 2 is going to be on that angle, and then 3 down through 6 is just going to run down the sternum. Okay. Remember, these points will be a little bit lateral, so I'll actually be treating the pec major. So we'll say anterior thoracic point 3 is about right here. First, I'll palpate that, tell my patient this is a 10 out of 10. I will then position them to the position of ease by flexing them up. Okay. I can put my knee under there to rest them. Once I have them in this position, I'll release the pressure on my monitoring finger, and I'll hold this for 9 seconds. While holding for 9 seconds, I think it's a good time to have some chicken for lunch. So that's what I like to do. And I'm just holding this position, just waiting for it to release. Once my 9 seconds is up, I will then passively bring the patient back down to neutral, and then I will rescreen looking for that 3 out of 10 or less. Those lower anterior thoracic points, that's going to be 9, 10, 11, and 12. If you remember, umbilicus is kind of our landmark for that. So superior to that is our 9, inferior to that is 10, and then 11 is going to be about right here in between the pubic symphysis and umbilicus. 12 is going to be out lateral on the iliac crest. Okay. Remember, you can use 9 in the seated position or in the supine position, as we are here on your practical. Let's treat point 10. All of these points will be treated using the same technique that I'm going to show you. Once we find that tender point, it's going to be on the side we are standing. I will press that and I will tell the patient this is a 10 out of 10. Okay. Then when positioning them, I'm going to bring the legs up, place them under my knee. Okay. That is my flexion. Okay. You may have to flex a little bit more, actually get their butt up off the table to get enough flexion to be in those abdominal muscles. I'm then going to side bend towards by bringing the ankles towards me and rotate away by bringing the knees towards me. Once I get this, I will press that point and see when I get it down to that 3 out of 10 or less, then I will release my pressure, holding this for 90 seconds. When I hold for 90 seconds, I like to eat, if you got my chicken there. The gain train doesn't stop just because you're doing counterstrain. Once my 90 seconds are up, you want to make sure you do this passively, but you'll bring the patient's legs back down to neutral, making sure you maintain contact with that monitoring finger, and then you will press and see if you got that down to a 3 out of 10 or less. That is your rescreen. Lower anterior thoracic points, we're going to find 7 is going to be just below the xiphoid, 9 is going to be just up from the licus, and 8 is going to be in between those two. Okay. We'll treat 8. Okay, so it'll be about right here. I will press that point in neutral, and I'll establish and tell the patient that that is a 10 out of 10 that they're feeling. I'll then get to the position of ease, which is going to be flex, side bend toward, rotate away. Okay, I can put the patient's arm over my leg here, flex them forward, and then side bend toward by bringing them over this way, collapsing that musculature. And then I can push them here to rotate away. Okay. I will then release the pressure of my monitoring finger once I get that 3 out of 10 or less, and then I'll be holding here for 90 seconds. I also like to take this time to eat. Just make sure that you don't get crumbs all over your patient. That's not good. Once my 90 seconds is up, I can then passively, of course, bring this patient back to midline. I can then reassess by pressing on that point and seeing if we got down to a 3 out of 10 or less. Your anterior rib points, remember we're going to find anterior rib 1 just under the clavicle, okay? And then ribs 2 through 6 are going to be on the corresponding rib and moving out laterally. So 2 will be here, 3 will be there, 4, 5, and 6. Let's do a treatment for rib 3. So if I found a tender point here, I would press on that point and tell my patient we're going to call this 10 out of 10. Okay. Then to move to the position of ease, I'm going to place the opposite arm over my leg. I'm looking for flexion, side bend towards, rotate towards for this treatment. So first I'm going to have them flex, and then by pulling my leg out, that side bends them toward, and then I can push them this way to get the rotation towards. You may have to add a little bit more flexion just to get to that point, and then I'll palpate it, ask them what the pain is now. I'm looking for them to verbalize a 3 out of 10 or less. Once I get that, I'll release pressure from my monitoring finger, and I'll hold them in this position for 90 seconds. This is opposed to the previous rib treatment that was 120 seconds. We're just holding it for 90 now. Once that 90 seconds is up, I will passively bring them back to midline, making sure the patient does not move. If you need to kind of lean them against you, that works. Once they're back in midline, I can press that point so my finger hasn't left it, ask them what the pain is now. I'm looking for that 3 out of 10 or less. And that is my rescreen. It's going to be the AO1 or the anterior lumbar point 1. Remember your landmark for that is going to be ASIS right here. I'll just go medial to that, kind of fall off that. This point is the AO1. I'll press that and tell the patient the pain they're feeling. We're going to call this a 10 out of 10. I will then put the patient into flexion by bringing the knees up, placing them on my leg here. And then I'm going to side bend towards by bringing the ankles towards me. And then I'll rotate away by pulling the knees in towards me. Once I got this position, I will press that point again, ask them what the pain is now. I'm looking for that 3 out of 10 or less. Okay. Once I have that, I'll release the pressure of my monitoring finger. Then I'll hold this position for 90 seconds. Like always, the gains don't stop just because I'm doing counterstrain, so I like to eat. You just don't want to get crumbs on your patient, but they understand if you do. It's all right. Once my 90 seconds are up, I will then passively bring the patient back down to midline, making sure I'm leaving my monitoring finger there. And I'll press and ask them what the pain is now. I'm looking for that 3 out of 10 or less, and that is my rescreen. Points are going to be anterior lumbar 2, 3, and 4. Remember our landmark for that, this is ASIS. If you palpate down, it kind of dips in, and then that last bump you feel before you fall off into just tendons and musculature is going to be AIIS, about right here. Okay. Remember your points, AL2 is going to be medial, AL3 is going to be lateral, and AL4 is going to be inferior to AIIS. All of these points will be treated using the same technique. So let's just do AL4. Okay, I'll press this point. I tell the patient, let's call this pain a 10 out of 10. Okay. I will then bring their legs up into flexion, placing them here. I'm now going to, on this one, it's the opposite of the AL1. I want to side bend away, so I'm going to push the ankles away from me and rotate towards by pushing the knees away. Okay. Once I find this, I'll ask the patient, what is this pain now? Looking for that 3 out of 10 or less. Once I get that, I'll release pressure from my monitoring finger, and I'll hold here for 90 seconds. And of course, sometimes you still just got to eat, even while holding. That's one reason I like Counterstrain so much, because it doesn't take away from my game times, and the patient doesn't mind. Once the 90 seconds are up, I will then passively bring them back down, watch your chicken, to midline, leaving my finger on that point, and then I can press for my rescreen and see if we got down to that 3 out of 10 or less. Anterior lumbar point, this will be AL5. Remember, that one's going to be on the pubic tubercle, so you want to start with your hands up. You'll palpate down till you find that pubic symphysis, and then we can come here. So it's going to be right there. That will be my AL5 point. Pressing on that, I'll tell the patient we're going to call this a 10 out of 10. I will then position them by bringing the legs up. This will be my flexion. Okay. Remember, this one is the side bend away, rotate away. So my side bend away again will be ankles away from me, and then my rotate away will be bringing the knees in towards me. Okay. Once I find that, I'll ask the patient what that pain is. I'm looking for that 3 out of 10 or less. Once I get that, I'll release the pressure of my monitoring finger. I'll hold here for 90 seconds. You want to make sure and wash all that chicken down with a lot of water. Once your 90 seconds are up, then you will passively bring this patient back down to neutral. Careful to keep your finger on that point, and then you'll press it for the rescreen, looking for that 3 out of 10 or less. Yes, and you're going to press there. We'll establish this pain as a 10 out of 10. I'll then move him to the position of ease by flexing, abducting, and externally rotating the humerus. So again, that'll be flexion, abduction, and now external rotation. And then once I get here, I'll establish that 3 out of 10. I'll then hold for the 90 seconds, releasing the pressure from my monitoring finger. Oh, perfect. Once my 90 seconds are up, I'll then passively bring him back down to neutral. Then I can rescreen by pressing on that point, looking for that 3 out of 10 or less.
This is Counterstrain for the long head of the bicep.
So for this Counterstrain point, you're going to feel in that intertubercular groove, or that bicipital groove in between that greater and lesser trochanter of the humerus. First in neutral, we'll press on this and establish that pain as a 10 out of 10. I'll then position this in ease by going into shoulder flexion, abduction, and internal rotation. So I'll bring that up into flexion, abduction, and internal rotation. Once I get to position of ease, I'll release the pressure of my monitoring finger, and then I'll hold here for the 90 seconds. Once the 90 seconds is up, I'll take it back down to neutral, and I can rescreen by pressing on that point.
This is the Counterstrain treatment for the lateral epicondyle.
So for lateral epicondyle, you're going to find it here. Just like medial, you're going to move a little bit distal to that and find where those extensor tendons are inserting there. We'll press on that in neutral and establish with the patient that that pain is a 10 out of 10. I'll then get to position of ease by adding extension to the wrist and a little bit of supination. Okay, once I get down to that 3 out of 10 or less, I can release my monitoring pressure, and then I'll hold this position for 90 seconds. Once my 90 seconds are up, I'll then passively take the patient back to midline and rescreen by pushing on that point and see if I got it down to that 3 out of 10 or less.
This is the Counterstrain treatment for the medial epicondyle.
For the medial epicondyle tender point, you're going to find your medial epicondyle here. You're then going to move a little bit distally to that where those flexor tendons insert. In neutral, we'll press on that and establish that this is a 10 out of 10 with the patient. I'll then move to position of ease by flexing the wrist, adding a little bit of pronation. Okay. Once I get down to that 3 out of 10 or less, then I will release pressure from my monitoring finger, and then I'll hold this position for 90 seconds. Right, can you hold this with your other hand? Yeah, that's good there. Just hold that. You guys know that I like to eat during counterstrain. And so, once my 90 seconds are up, I can then passively take this back to midline and rescreen by pressing on that point and seeing if I got that 3 out of 10 or less.